all. Myself, Jeevitha, working as Assistant General Manager for Training and Education. So it's my pleasure to take session, and I would like to thank ISS CCM to give this opportunity. So let us start our session.
Yes, Jeevitha.
Yeah, ma'am. I'm sharing the screen, ma'am.
Okay.
My screen is visible, right?
It is, yeah.
Yes, ma'am. Okay, before going to start my session, I would like to tell about the catheters. In ICUs, the catheters plays a major role because whenever the patient is on catheters, as a nurse, we have to look after the patient and we should know what are the different types of catheters. And mainly today we'll focus on this session, how to take care of the catheters. So the care of catheters are very important in administering the medications. And also it will be help. We have different types of catheters. So we'll discuss about few catheters and what is their importance. When the patient is on these catheters, as a nurse, what is our major responsibility, we will see. So before going to start, what is the difference between catheter and tube? Can anyone text in the chat box? What could be the exact difference between catheter and tubes? Both are similar, or do we have any difference? Anyone? It's okay. So mainly the catheters and the tubes are different. Mainly the catheters are hollow in shape, and mainly which will be inserted into the vessels or into the body cavities, mainly to administer the different types of medications. So the catheters are divided into IV cannula, Foley's catheter, central line, arterial line, and epidural catheter. These all the catheters. So mainly the catheters are helpful to administer medication. At the same time, it will be helpful to drain out the urine. Each and every catheter has a different importance. So let us see first IV cannula. So most of them knows IV cannula importance. The IV cannula is a catheter which will be inserted into the vein. So most of the time, the catheter is inserted into the vein. Might be it will be into the metacarpal veins or the basalic or cephalic. But whenever you are introducing into this catheter, as a nurse, you have to look after the complications. So let us see what is the complications, everything in detail. As I said, the catheters, every catheter has different importance. So mainly the catheter is helpful. IV catheter, especially the peripheral catheters, are helpful to administer the medications and to maintain the fluid and electrolyte replacement, and also which will be helpful for the nutritional support. Apart from that, which will be used to administer blood products also. So mainly, as I mentioned here, I would like to highlight, though we are not much focusing upon the insertion protocol, but when you are selecting the veins, most of the time you have to prefer first choice as a dorsal, means metacarpal veins. Because as a nurse, we are the first person who will put most of the time IV cannulas. And it is means important responsibility is you have to select for metacarpal, then you need to go for basalic and cephalic. Please do not select first basalic and cephalic. Why? Because once we got swelling, otherwise thrombophlebitis, it is very difficult to utilize other veins. And last choice will be the cubital fossa. But first and foremost is you have to use for metacarpal. And if the patient is having any fistulas, so please do not use that hands. And especially for forearm veins, you should not use. Otherwise, metacarpal will be helpful. And here I would like to show the picture. What are the different types of cannulas and what is a gauge? So here why I took this slide means to know, because 14 here we have disproportionate. Once the catheter size is small, the gauge will be more. So that is the main importance you have to remember. And whereas it's 24G and 22G, most of the time we use for children and elderly patients. And whereas in ICUs, most preferable cannulas will be 16 and 18. especially because we have large amount of fluids will be administered, and peripheral cannulas are not main central lines also will be used. But if the patient is not on other medications, so as a priority, first we can use for the peripheral IV cannula, that is IV intravenous catheters. So once if the patient is on IV catheter, as a nurse, what she has to monitor? Can anyone, few responsibilities, can you chart? What could be the important when the patient is on IV catheter? What are the things you have to follow? Okay, fine. So mainly whenever the patient is on IV catheter or any catheter, before taking handover, first you have to look after that site, whether the patency is fine and what is the date of insertion. And whenever you are handling that catheter, you have to follow sterile precautions. I would like to highlight here, see, when we are creating a port, ultimately there will be a chance of infection. So these are the catheters which we are creating, opening into the body. Ultimately there will be infection transmission. So whenever you are checking the catheter, means IV catheter, you have to check for any cannula swelling, or whenever you are administering any fluids or any medications, first you have to clean the site and keep the site very clean and dry, because once if it is wet, there will be a chance of growth of microorganism. And all, whenever you are taking the handover, first and foremost, you have to monitor the site. If you could see any complication, please try to escalate. That is a main responsibility of the nurses. And look for signs of phlebitis. As we all know, the phlebitis is inflammation of the vein. Phleb means vein, itis is inflammation. So once if whenever you put cannula, we could not say that it may get immediate swelling or it may take time. It depends upon the how many types or how what are the fluids or medications will be administered. So whenever there will be whenever you are noticed any redness or inflammation, please try to relocate. Means you should not administer or you should not push the medication. And wet or soil dressing, please try to change immediately as early as possible, and flush to confirm the patency before administration of any drugs, because there will be a chance of after phlebitis, it may lead to extravagation, infiltration, because the purpose is to administer the fluid, not to give any infection to a patient. So as per the hospital policies, you can either SAS, nowadays heparin is not administering through this, and you can follow the SAS method, which stands for saline, administration of medication and saline. One thing I would like to highlight here, whenever you give any medication, because most of the hospital nowadays, we are using cannula with extensions. So if you give 2 ml or 3 ml with that, means might be you are aware of the extension, most of the medication will be in that extension only. The purpose, whatever we could reach, we may not do that. So for that reason, whenever you administer any medication, you have to flush it. Then you need to make the IV line very, patency should be very clear, because putting the cannula is a very difficult task. At the same time, you need to maintain it also properly. In case of any spelling, because why I have highlighted in this red color means most of the nurses, if it is spelling, will try to push it off, no problem. But please do not do that. Immediately, if you have seen any redness or swelling, please try to remove that cannula. Unnecessarily, do not give any infection to a patient. So complication could be IV site of infection. Once you should not follow the sterile precaution or hand washing, ultimately it will cause the infection, cellulitis, infiltration. What is the difference between infiltration and extravagation? Anyone, please. It's like an interactive session. If you have any answer, please, you can chart in the chat box. What is the difference between infiltration and extravagation? Fine. So extravagation is mainly caused by vesicant drugs. So what happens if you could not, means whenever you are administering the medication, if the patency you did not check, whenever you did not check the patency, you have administered the medication, if it is lodged or if it is moved from the vein, the fluid, whatever you are administering, it may escape to the subcutaneous tissues. Because of that, the patient may get extravagation, and infiltration, it may cause more mainly with the non-vesicant drugs. So major complication of IV cannulization, phlebitis, extravagation, and infiltration. So once a patient develops extravagation and infiltration, it is very dangerous. So as a nurse, if you have seen any problem, please try to remove that, and thrombophlebitis, and there will be a chance of erythema. So these are the complications you need to monitor when you are checking the cannula. So to summarize the catheter, IV cannula especially, first and foremost, you have to check every day for the patency. And whenever you administer any medication, please try to follow the SAS, saline, antibiotic, and whatever means next saline, you have to push it to maintain the patency. And this is a scale which will be very helpful to identify a visual infusion phlebitis. The name itself, we can say the phlebitis, which we can see with our eyes. So because of this, there will be a means when you have seen phlebitis, you need to, we have different scores. So as per the guidelines, whenever you have seen score 2, immediately you have to resite the cannula. So you can see mainly they will complain about pain, redness, when there is a pain or erythema. So we have different number. Based on that, you have to see and observe the cannula. And most of the time, make sure the cannula should be no signs of phlebitis. So always it should be VIP score will be 0. Then main golden rules are wash hands, disinfect your hands. Most of them know washing hand, but you have to follow. And prepare the vein puncture site carefully. See, once, not only whenever the patient is on catheters, first insertion time also you have to maintain the sterile precaution. Insertion time, during, and removal. This 3 time means way you have to prevent the infection. And use flexible catheters. And select the smallest catheter gauge if possible. As I said, right, you need to select the site accordingly and based on the purpose. And always check the physiochemical properties of the drugs. Because why this point I have taken, most of the vesicant drugs, as I mentioned, like KCL and chemotherapy drugs, most of the time we cannot administer through a peripheral line. The preferred site could be the central line. So these are the things you have to follow. And next, coming to the urinary catheter. I think the IV catheter you have cleared. Then next we'll see urinary catheter. The main purpose of, somebody is asking few questions. Extravagation, vesicant drugs into whatever questions you have, please you type in the chat box. After our session, we'll clarify your doubts. Then coming to the urinary catheter, mainly we have different types of catheters, like retention indwelling catheters, intermittent catheters, and suprapubic catheters. So main purpose of the catheters are we have different ports. Whenever you are using the dual catheter, you all know, right? Mainly we have balloon inflating port and urine drainage port. So whenever you are handling the catheter, because this is a very sterile procedure, when the patient is on catheters, you have to follow the bundles that we will discuss in detail in further slides. So the main purpose could be like sterile, whenever you want to collect any specimens and measurement of urine hourly in ICUs, Foley's catheter, because if the patients are bedridden and we have to continuously monitor the urine output. So ultimately, based on the purpose, you have to put the catheters and measure the residual urine. For that reason, you will put the catheters, the Foley's catheter, which will be inserted into the urethra. And whenever the procedure we are not discussing in detail, mainly when the patient is on Foley's catheter, what is our responsibility? So being a nurse, what she has to look after. So first and foremost, as I said, all the foreign bodies, like these are the catheters which will create infection. So whenever the patient is on Foley's catheter, you have to give the Foley's care. Mainly the tray containing should be surgical gloves and small pack, betadine, and a Macintosh or the spread, means disposable sheet we have to use. And mainly you have to perform the hand hygiene. Might be you can notice hand washing is very, very, very important. 90%, 99% of infections will be reduced if you follow proper hand hygiene. So hand hygiene plays a major role in controlling or means most of the time the infections will be reduced by following proper hand hygiene. You have to arrange all the articles and you need to explain the procedure. When you are giving Foley's care, you have to put protective sheet and position the patient. So when the patient is on this Foley's the catheter, as a nurse, you have to give care. So every shift wise, you need to give the care. And whenever you are giving, you have to pull 1 inch and you need to clean the site. Most of the time, see, as per the new guidelines are telling, you have to use bath wipes like soap and water, which will be very helpful. And we should not use other disinfectants, which may cause irritation to that. And the priority will be the soap, the bath wipes you can use to clean the site. And perineal care also you have to give when the patient is on Foley's catheters. And push the catheter. After giving the care, you need to push 1 inch into the bladder. And always you have to secure the catheter with proper plaster. And discard the waste, place the patient in comfortable position and cover the patient and segregate. As per the protocol, you have to segregate the waste. At last, you have to hand hygiene and documentation. So when the patient is on catheter, as I mentioned, how the IV catheter is important in VIP score, how it is helpful to identify the phlebitis. Even this Scotty bundle, the bundle, can anyone tell me what is bundle? Bundle? Yeah, bundle is a set of protocol or interventions which will be followed collectively to reduce the infection and to improve the quality of care. So mainly, this catheter infections will be reduced, and whenever you are following the parameters 40 in the bundle, you need to always use closed drainage system. And this catheter should be properly secured, and make sure that the bag of this urinary bag should be always below the bladder level, not above. Because see, most of the time this mistake could be happened when you are transferring the patient, and sometimes you may not clamp the catheter, or there will be a chance of backflow. So unnecessarily the patient may get infection. So please try to make sure that whenever you are transporting or whenever you are making the patient on bed, please try to put the bag should be in bladder level, below bladder level. And catheter care, as I mentioned earlier, you have to follow sterile precautions, aseptic techniques whenever you give catheter care. Because once you do not follow the catheter care properly, again, there will be a chance of infection. And single-use gloves, as I mentioned, the insertion is sterile procedure. At the same time, care also you have to follow. And separate jug for collecting. Most of the time, what happens, whenever you are emptying, you have to empty, then you need to flush it. And again, you have to come with the, clean it, and you need to go to another patient. Same jug may not be used for all the patient. And you have to, whenever you are emptying, make sure that it should be documented immediately. So these are the parameters of cotting. So mainly aseptic techniques you have to follow, daily catheter care you need to give, make sure closed drainage system to be followed, and whenever you are emptying, the tip will be cleaned with the alcohol swab. There will be a chance of contamination. And coming to central venous catheters. So as I mentioned, we have different types of catheters like peripheral and central. Name itself is central, which will be passed into the 1/3 of the vena cava. So
Jeevitha, you are not audible.
Now, ma'am?
A little more?
Now?
Yeah,
is
better. Yeah, true.
Okay. So the types of central lines, we have different central lines like single human, triple human, might be have seen. These are the central lines. So most of the time we see the catheter selection will be done as per the requirement. So whenever you go to triple human, might be you may think that this catheter may have only one end. But coming to the central venous catheters, we have different tips like we have proximal, distal, and medial. So based on that, we have different ports. Most of the time, whatever we are having end, it is a proximal. And we have distal and medial. So why I'm telling these points means, most of them think they will have only one opening at the end. But it is not like that. We have different openings in different sites. So whenever you are administering any medication, it may not be mixed, and based on, means whenever you are pushing the line, you have to push it properly and you have to flush the lines before administration of each catheter, means each line. And the maybe this central venous catheters are inserted into the IJV, and sometimes we will put neckline. Neckline is not into the jugular vein. It is an external jugular vein, and few catheters will be inserted in the subclavian vein and few will be a femoral vein, and based on the purpose, the catheter will be introduced. So same as we have the 40 bundle, how we means infection, how we can reduce by following these. Even for the central line monitoring, we have CLAPSI bundle, that is central line bloodstream infections. As this follow aseptic techniques and clean. Always you have to clean the site whenever you are administering the medication. This thing you have to follow even peripheral lines also. And see why I'm giving much importance to the central lines, as I mentioned, which will be direct contact to the superior vena cava, because infection once started, it will be spread immediately, and you have to check blood flow. Because whereas in when central lines, if you could not find the swelling immediately, if you push it, then again the patient may get other complications. So flush the catheter each medication administration. Whatever protocol you are following for the peripheral lines, please try to follow for central line as well. And if patient on inotropes, do not flush the line. This is very, very, very important. Please, whenever the patient is on inotropes, do not flush that line. Because suddenly there will be a arrhythmia, there will be a chance, because you are flushing the line means as per the requirement, you may not administer and maintain patency of the catheter. And check the dressing site every day. You have to check. Make sure that the dressing should be very transparent. It should not be like nowadays, most of them are using this transparent dressings only. We should not use any dynaplasm. It is very difficult to identify the site if it gets any swelling or redness. And always wrap the central line with green sterile towel in order to maintain the sterility of the catheters. And parameters of the CLAPSI, very, very, very important. You have to maintain daily monitoring any local signs of infection. Might be you have noticed any redness or any swelling. Once you want to administer the medication, if the medication is not being administered, please try to escalate. Dressing should be changed if it is wet or any soil dressing, and assessment of readiness to remove. Means you need to check if really the patient is not on medication. If the central line is requirement is not there, you have to explain, or you need to tell the doctor about that, and based on the doctor, line could be removed. And coming to the arterial line, very important. So main purpose of arterial line is to maintain the hemodynamic monitoring and to have the ABG sampling. Never confused with central line and arterial lines. Central lines are inserted into the vein, whereas arterial lines are introduced into the arteries. Either it could be a radial or the femoral, but most preferred site and easy to identify or any complication means the best site is radial. And radial artery, as I mentioned, brachial artery and the femoral artery, these are different sites. We will insert the arterial lines. Same like that catheter, lines only, this peripheral line only, but it is introduced into the arteries. So when the patient is on artery line, please do not administer any medication through that cannula. In few institutions, they will write with red, means it is an indication, because most of the sister, what they think, if it is there in the metacarpal, might be they think it is a vein, means like normal peripheral cannula, because arterial cannula is meant only for monitoring the blood pressure, that is invasive blood pressure, and it is helpful to take the blood samples, but do not administer or do not inject any medication into arterial line. Ensure that the flush bag has adequate fluid, means might be you are aware of it. Every time it will be connected to the transducer, and you have to use that saline and observe for any air bubbles, and monitor whenever the patient is on arterial lines. You have to monitor for the peripheral lines, hands or any chance of necrosis. These are the things you have to monitor, and you have to check for the patency of that cannula. Might be aware of it. You need to do the zeroing and whether the blood pressure is coming properly. Everything you have to look after. But one important thing, please do not administer any medication through arterial line. And whenever you remove the line, you all know, because the arterial pressure, blood flow will be more comparing to the vein, you have to apply the pressure in order to prevent the bleeding. And next, coming to the epidural catheter. As I said, the epidural catheter also will be introduced mainly for the local anesthetic agents and to administer the pain medication. So which will be introduced into the epidural space. Same for these catheters also, whenever the patient is on catheter, you have to check for the site. See, whenever you are taking the handover, not only seeing the catheter from the outside, you need to check for the origin till end. That is very important whenever you check any type of catheter. Either it could be IV cannula or central line or Foley's catheter, anything you have to check for the origin, and you need to check for the patency, and then you need to administer any medications. And before giving any bolus, all things also, and whenever the patient is on epidural catheter, separately it should be labeled to avoid confusion. As I said, right, you should not confuse with the catheters. In case of any epidural infusions also, it should be prepared under the anesthetic guidance. If the patient had any complication, please try to stop the infusion and immediately escalate. And if given any bolus medications also, it should be documented properly. And coming to the surveillance forms, as I mentioned, the bundles are very helpful to reduce the risk of infection. And also it is very helpful to improve the quality of life. So as I mentioned, we are discussing about the catheters, whereas for IV cannula, we have VIP score, because scales are very important. It's like a important to reduce the infections. Like that, when the patient is on central line, we have CLAPSI bundle. And when the patient is on urinary catheter, we have COTI bundle. So in this, mainly you have to see whatever bundles I have said before, like you need to check for the drainage, and it should be maintained closed drainage. Always it should be below level, and every day you have to give the Foley's care. Like that, every day, if you make a checklist, immediately what happens, if you have seen any infections, you can rectify and you can reduce the infection. So one humble request is, this checklist you have to properly fill by seeing the parameters. Checklist should not be like a tick list. This is a humble request from my side. So always check the parameters properly and try to check it, because this bundles why we have established or why we have developed these bundles to reduce the infection rate. See, as I mean, most of the nurses are attending this session. We are the frontliners, and we will be with the patient for 24/7. Whenever infection comes, if you identify early, the infection will be reduced immediately. And so the hand hygiene is very, very important, because the hands are, it can break the infection or it can create the infection. If you properly follow the hand washing, really you can break the chain of infection and you can prevent many infections. Clean hands save lives. So one thing I want to tell here, might be you know about these catheters. Extra thing might be 2-3 parameters I'm giving extra knowledge to you, but knowing is not enough. We must apply. Willing is not enough. We must to do. So as a nurse, you all know, whenever you are administering the medication, you have to clean the site with alcohol swab. And whenever you have seen any swelling or redness, immediately you have to escalate and try to put the urine bag always below the bladder level. So these are the things you know it, but I'm from as a nurse, what I'm requesting you all, please try to follow whatever you know, and you have to apply to prevent infections, and try to give discount to a patient in reducing the infection, not to bonus, because you should not raise the infection to a patient, or you should not give any extra infection to a patient. So thank you all. Thank you so much. Ma'am, few questions.
Jeevitha, that was a very knowledgeable, very clear, a very thoughtful talk from your side, especially for all the young sisters, those who have been inducted into this profession. So for them, I believe it was a very clearer way of telling them what we expect of them and what is their important duty and why they are here in the ICU or the hospital. All right. So we have a lot of questions to be taken.
Yes,
yeah, so we will start with the question first. Or should we have There's a lot of thank yous coming. I think the class has been well appreciated. So as one thing I want, being an intensivist and being in the ICU day in, day out, I really appreciate the work done by my sisters. And I think most of the sisters, those who are fairly senior, those who are fairly old in the profession, they're doing a really fantastic job. But the problem arises when we have got a new trainee sisters. And the best part is that they're very keen to learn. They're very keen to know. But the problem is they do not know how and when to apply. See, this is what happens when they have not been trained enough or they have not got enough exposure. So Jeevitha has adequately covered what all to look in the arterial lines, the catheters, the Foley's catheters. What I would want to convey one thing is that especially when we're using an arterial catheter, the very important thing first is when the sisters take the handover in the morning, they must assess the patients from tip to toe with regards to catheters. The patient will have an IJV, they may have an extrajugular catheter, they may have an arterial catheter, which can be radial, which can be femoral. What I would expect my sister is to see whether the first thing first, the central venous catheters, are my 2-3 ports, they're working adequately? Are they aspirating well? Because I'm telling you, every day, maybe sometime or the other, I see my central line ports are not aspirating. And we are giving the drugs continually, which is not right, because the sisters did not notice, the doctor did not notice, and when there's some obstruction, then we check the ports and there is no flow at all. So sisters, if they check in the morning time or in the duty handovers, the 3 ports are working or not, that will be a good sign of that they're seeing the patient properly. Second thing is, you should know what infusion you're giving through your central lines, what infusions you're giving through your extrajugular catheters, and which ones you're giving through your peripherals. In the neuro ICU, you should know that we are giving very concentrated solutions like 3% saline. They cannot be given through a large bore catheter from the peripheral side. For the very fact, we'll be having a thrombophlebite in the patient the next 24 hours also. So even if the doctor has instructed to start 3% saline, please see what is the site available to you. If you have got peripheral catheter, no 20 gauge, no 18 gauge for my 3% saline. I would always prefer a EJV, which is the external jugular catheter, or best is central line. So you have to convey that to doctor, or if the patient is already on these lines, take these lines and then start your 3%. Next, most commonly used solutions what in the ICU is the KCl, potassium chloride. It's a very dangerous and a very important drug. And the very fact that we're using it like day in, day out because of the hypokalemia. Now, how do you give KCl? So there are 2-3 ways. Best part is if you're giving it through peripheral, remember, it is always in 1 pint dilution. We never give 40 ml, 50 ml saline to the peripherals. No way, regardless of the size of your catheter, to be on safer side. Because any patient who's fairly stable, who has got hypokalemia, I may not be requiring central line to give my KCl, but they will be having a 20 gauge or 18 gauge. So remember, you have to dilute the KCl, the 60 millicoulomb or 40 millicoulomb in a pint of your NS, never in your 40 ml, 50 ml syringe, infusion syringe. If there is no peripheral line available, of course, we'll be having the central line. So through central line, you can give 1 millicoulomb or 0.5 millicoulomb per ml, which amounts to like 20 millicoulombs to 40 millicoulomb in your central line. All right, that will be in your 50 ml infusion. But be careful, if you don't have, you inform the doctor, sir, the patient is not having jugulars, central lines or extrajugular. So we have to secure it. Or if you're giving through peripheral line, 20 gauge, or if you're giving through your 18 gauge, always ensure it's in dilution of 1 pint, which is 500 ml of the NS or half NS. Okay, that is 1 point. Then, when we have the arterial lines, especially radial arterial, please ensure that there is a free flow of the blood from the short 10 centimeter side of your insertion, not the long one which goes right to the transducer. No, because remember, their 20 gauge is a very small gauge, small caliber artery. If you're going to push lot of saline, lot of flush, you're going to cause more thrombophlebitis but the very fact that the small gauge is more prone to cause more blood clots, simply. So whenever you have to flush the line, whenever you have to transduce, always use the nearest to the port, 10 centimeter port, and then you transduce and flush the line. But please be careful that you have to ensure that there is aspirate of blood at all the times. Because if there's a small air bubble, number one, there'll be no free flow aspirate. Number two, you'll be having a faulty arterial line trace, which will give you a faulty reading. So what happens? You will be having a faulty trace. The BP shows 90/40. We all get scared. We start vasopressors. No, that is not to be done. If the BP is low and there is no waveform, do not believe that arterial line, that arterial pressure. It is faulty. For many reasons, the arterial line is not working. There's air bubble which is coming in the transducer line. Best is you aspirate, you transduce, and zero the line. Only when you get a nice trace with a dicrotic notch, that is the BP which is to be believed in. Because I've seen very commonly, my sisters, madam, BP 90/80. No, is the right BP? No, it is not right. So whenever there's fluctuation in the BP, whenever the BP, the arterial trace is not proper, ensure the trace is proper. Then you see the arterial blood pressure, and then you take your decision on implementing your vasopressors or starting a new vasopressor line. Okay, so that is one thing. And nothing we can emphasize more than the sterility, hand hygiene, use of alcohol swabs, use of hand rubs adequately in your palms, between your fingers, in your the way we are taught all the 6 ways of cleaning your hand. That's very important, because you must realize, my dear sisters, that you are the point of contact between the patient and the doctors. Any small hint of the patient's changes in the vitals, in the conditions, temperature, fever, durations, erythemas, anything, we will not come to know unless you know about it. And you will only know when the mind knows, because eyes don't see what the mind do not know. All right. So let's have question answer sessions now. Hello. Am I audible? Jeevitha?
Yes, ma'am. Yes, ma'am.
Am I audible?
Yes, ma'am. Yes.
Yeah. Okay. So let's open the round
box,
for a few question answers. Yeah, let's have the questions, the chat box.
One sister asked, ma'am, if you push through arterial line, what could be the complication? Why we should not push?
Yeah. So number one is, which line is it? Is it arterial radial or femoral?
Arterial.
Okay.
She has given arterial, ma'am.
Okay. So we'll take both the case scenarios. So see, radial artery 20 gauge cannula. Okay. So we should not use larger volumes, because there are three ways. One is 10 centimeter near the patient end, and there is one right at the transducer level. So I always request and teach my sisters to use the short 10 centimeter one for the aspiration and flushing. If you use a large volume, you're going to cause more turbulence in the narrow gauge vessel. And more turbulence means you're going to cause more blood clots disseminating. All right. And more risk of the arterial thrombosis, not the phlebitis, but arterial thrombosis. So these patients will be first starting to have cold fingers, sinus fingers, or they may be having blebs. The signs for arterial thrombosis are early gangrene. That is important of not pushing the saline, not flushing it rapidly, especially from the nearer end. Number two, if it is femoral is a central axis. So there we can use 10 ml push, but as again said, use the shorter port, because the shorter the port, you'll be using the less volumes. Okay, and the rest transfer the clot dissemination or the clot embolism. So preventing any thromboembolism. Jeevitha?
Ma'am. Now
can you hear me? Am I clear? Okay.
Clear,
next question. Yeah.
Can we give injection mannitol through peripheral line?
Mannitol?
Yes, ma'am.
No, through extrajugulars, if you don't have a peripheral line. As I again said, if you're giving it, use the smaller vein, the 20 gauge vein, because there the caliber is less. So less chances of thrombophlebitis. But keep monitoring it, keep monitoring for at regular frequent intervals for any signs of redness, erythema, pain. But mannitol we always prefer through the either central line or through external jugular, or maybe through a bigger gauge.
That's all, ma'am. 2 questions only are there.
Oh, yeah, I see this. There is one question here. Joyce is asking that regarding some 3-way cannula. Can you read that, Jeevitha?
Where it is, ma'am?
Person called Joyce is there. She's asked some question. Okay. So, yeah, thrombolytics administered throughout? No. Yeah. This is actually, if the procedure is being done in the cath lab, okay, so their intra-arterial thrombolysis is done. So under the, in the cath lab, when we have got the fluoro is there, under vision, they do administer, but routinely we do not give in the arterial line. Through the arterial line, the thrombolytics can be administered through the interventional radiologist when they're doing it under fluoro. When they can see the the clot lysis can be seen easily. Jesse. Okay, next question is, how long to keep peripheral line central? Okay, there is no clear-cut guidelines. Like we don't have that 5 days, 6 days, 7 days. So number one, if your peripheral line is going easily, there is no induration, there is no erythema, there is no blockage, there is no swelling around the line, you can keep it for as long as it is possible. Remember, in the neuro ICU, in the ICUs where patients are not mobilizing easily, where they're immobile in the bed, do not use the lower leg or the lower dorsal veins, because that is going to enhance, that is going to cause your thrombosis, because the patient is not moving, bedridden. So there's going to be more venous stasis. Okay, so avoid the lower limb venous cannulations in the bedridden or a prolonged ICU care patient. That is one thing. Probably prefer the upper limb or the central lines for these patients. And as again for central line, even if I keep it 3 days and I have a patient having fever, tachycardia, and site induration, I will remove immediately. I will not wait for the period of that I have to wait. I will send the cultures from that line and a possible other one from the peripheral line. And then I will change central line, thinking it's a CLAPSy, the fever because of the catheter-related lines in fever. Then I can change. But there is no duration of central lines or peripheral lines. Or if the patient was in the other hospital and then it has come with fever, so we do not know the situation or the kind of infection he's having, definitely I will change my lines because I do not know what kind of care was given in the other hospital. When the patient has come, stabilized, and then I would change the lines as soon as possible. That is one indication. Outside lines, outside polys, patient having source of infection, if you think it's line related, then of course I will change it regardless of the number of days of the line in situ there. Am I clear?
Can we give thrombolytics through yes, ma'am. Can we give thrombolytics through arterial lines? Yeah. One question being asked by one sister.
I know, I answered that. See, the thrombolytics are intra-arterial. We do not give it really in the ICU. In our setup, it is given in the under the fluoro by an interventional radiologist during the clot lysis when they're doing it in the fluoro. At that time, they do give intra-arterial thrombolytics, they give, but that is under the guided care of the fluoroscopy. Routinely, we do not give.
Ma'am, one more question, ma'am. Lumens, which lumen will prefer to give the vasopressor, like distal, proximal, or medial? I think so. The question is asked.
No, that lumen, which lumen? The proximal one. The proximal one.
Means the tip will be the end of the tip, no, ma'am?
No, that is the first one to form the tip. That's the proximal one.
Okay, ma'am, we can answer. And can we load injection epsilon 1000 mg through a peripheral line? No, I think so.
Come again. So what is that?
Can we load injection epsilon 1000 mg through a peripheral line?
Epsilon?
Yes, ma'am.
That is a phenytoin, huh?
Some asked, Anujos asked, ma'am.
The question is not clear to me. What is it?
Might be her question is, can we give epsilon 1000 mg through a peripheral line? But that much mg we may not use, no?
No, but that is a phenytoin, no?
Yes, ma'am. Anujos, if you, Anujos, your question is not clear. Please try to remake your question format if possible.
Okay. I have a lot of questions here. They look quite practical. I'll just come back to that question later. So
Yes, ma'am.
why, there's one question Nisha is asking, why central line is chosen to given in femoral arterial commonly? I don't understand that.
Might be why we will use central line than femoral line, I think, ma'am. Why we prefer?
Why we choose? Okay. So why we choose central line in femoral is there are a lot of, if the ICU patients, they're not the normal patients. They are having shortness of breath, they are edematous, difficult airway. They may not lie down for the central lines in IJV subclavians. So in that scenario, and the patient is very sick, we can't lose time in securing the IJVs. So femoral artery or the femoral side is chosen because the ease of accessibility. I can have a patient supine and I can place a femoral catheter, whether it is arterial or femoral. Other thing is, this femoral artery is most easily accessible. We can do blind also. Okay. So ease of accessibility, the patient can lie in little head up position in the patient like having difficulty in lying down straight. So in those situations, we use femoral arterial cannulations and we use femoral CVC cannulations. Nisha, that was your question. Okay. Then there is one question sent from Jobin. Central line triple lumen catheter, which line used? This is not the most proximal port is used for your vasopressors. Okay. Other thing is, can we load injection epsilon 1000 mg through peripheral line? Yeah, epsilon, I think it needs to be diluted, isn't it?
TPN infusion, any precautions through a central line?
TPN infusion, yes, that's a very, I also forgot to mention TPN. Total parenteral nutrition. My dear sisters, you have to understand, it's a very important cause for patients' morbidity in the terms of causing fungal infections. Okay, so TPN is the last resort to give patient nutrition to the patient. Okay, so the point is how to use. It is a dedicated line. If you're having triple lumen, so we are using, say, we can use the proximal port. We can use the distal port, middle port. Whichever port we're using, it has to be dedicated only for TPN. This is depending upon the type of TPN. There are actually two types. But there is one TPN which you can give through central line, and there is one TPN which you can give through peripheral line. So pericabi is easily available to us, and we can use it through 20 gauge even. But remember, these TPN are not to be mixed with any other antibiotics, with any other infusions, with any other drug dilutions. No, they're only meant for TPN and only TPN. Okay, and the same protocol we followed for the IJV TPN also. If you're having a TPN through central lines, it's a subclavian, to the jugulars, dedicate that line for TPN only and do not touch it. Wrap it with a clean gauze and say line dedicated for reading that it's TPN line, so that we can use through central line also. Other thing is, we have something known as peripherally inserted central lumen catheters. So even that can be used for your TPNs. The regular TPNs can be used. But as again I have said, they are not to be mixed with any dilutions, not to be used with any other antibiotics, only meant for TPNs.
One more question, ma'am. Ma'am, sometimes we face, sometimes we're facing that.
Yeah, we are facing that in three ways. One of the lumen got clotted.
Even also?
And even all flashing that line. So in this case, one sec, we are facing in three ways. One of the lumen got clot, okay, so it can't flashing the line. So in this case, what should we do and how we can easily prevent clotting if no infusion going on? No. One, Joydev, see, if the three-way lumen has got clot, for the very fact, we do have Heplock, is a very dilute solution of heparin, or if under doctor is there, we can use lignocaine also, but Heplock we do use. We can push the Heplock but that we use only 0.5 to 1 ml. If one lumen has got clotted, doesn't matter. You close that. It happens. Okay. If that lumen is not working, do not use it. But at the same time, if you have got the other 2 lumens working, use them. But remember to aspirate freely and frequently. Because even that line, that means there's a thrombus line close to close to the central line in the lumen. Maybe there's some clot around, which is not obstructing the other 2 lumens. It happens. So if one lumen is not working, kindly inform your sister in charge, inform your colleagues when they come to the next handover, and do not use that port. Use the other 2 ports, always confirming the aspirate blood flow first. Okay. So in that case, you should not use the one which is blocked, and you can prevent. See, if there is any site, any one of 3 ports are not working, they are being clotted. If the 2 ports are clotting, you use that line. Next, say if again it is clotting, the line are not working, remove the line if the condition is amenable. Like when there is no coagulopathy, patient is not having any high INR or low platelets, we can change the lines under cover of platelets or FFPs if the coagulopathy is present. Okay, but it's very right that you have to first ensure that the lumens are working properly. That is your job to see when you come and see the patient. Okay.
Yes, ma'am.
Okay, this is a very good question, Sangeeta. How to flush catheter while stopping anatropes? All right. See, Sangeeta, we are using multi-lumen catheters. If the doubt is there, immediately you disconnect the inotropic catheter, connect to the other ports. Okay, and then you aspirate the blood from the line to which inotrope was going on. Okay, and once you aspirate the blood, you have taken out that amount of your inotrope, and then you can flush with some 0.2, 0.3 ml of saline. Okay, and at the same time, you have got another infusion pump ready. Okay, so when you have another infusion pump ready with the same NORAD or adrenaline or dobutamine or whatever you're having, you flush the line and go with the flush running flow and connect that to the line which is already flushed. So it's meaning thereby that at no point of time your patient is without the inotrope. You got my point? We've got 3 ports. If you're really confused, my inotropic port is not working, don't worry. You disconnect that port of inotrope and connect to the other port, which is not important. Like it could be your KCL, it could be your human actrapid, or just a simple IV. For time being, you connect that port to your another port. Same time, you have got another infusion pump ready, and the inotropic port, which was the previous thing not confirmed, you aspirate blood from there. And when you aspirate free flow, you have taken out that amount of vasopressin or whatever inotrope. After you have aspirated that catheter, you connect the new infusion pump or infusion pump, and then you start the infusion. So that way, there is no time loss in the patient by not giving inotrope. Secondly, you have flushed the line by taking out the inotrope from that line. So you have prevented the sudden surge of inotrope in the patient. Am I clear, Jeevitha?
Yes, ma'am.
Yeah.
One more question, ma'am.
Yeah.
If not giving any medication.
Yeah.
If
okay,
not,
that's also very good. Yeah. Tell me, Jeevitha.
If not going any medication through a central line, the frequency of flushing, because if any medications are not there, what is the frequency of flush? How frequently we have to flush?
Yeah, that's what I'm saying. See, when you have a duty changeover, after 6 hours, 8 hours, second sister comes in. So she does not know about the patient, right? That's what I'm going to tell you guys. When the new handover takes place, a new sister comes over, she must, unless indicated that the ports have been closed for a long time, she must aspirate and check. Okay, why it is not aspirating? Inform the duty doctor. Secondly, if anyway patient is sick and endotomes are going on and the BPs are stable, that means patient is getting adequate dose of inotropes. But in doubt, when you're aspirating, because we do not aspirate very frequently inotropic port. If other 2 ports are working, we assume even this is working. But if the other 2 ports are not working, then we really need to check the other inotropic port also. Okay. So there is one question here which is quite relevant. Ma'am, in central line, why 3 types of color? Yellow, blue, white. Yes. See, these color coding are very important. These are telling the gauge. Okay. So the yellow color, blue, white, these are distal ports. The one with the more proximal, medial, and distal ports. So
yes, they will have number. You will have the gauge number.
So yeah, there's a gauge number. And these are not same lumens. See this, the blue one is the narrowest one, okay? And the yellow is the biggest one, through which we can give we can transfuse volume of. See, even in central line, with the biggest gauge is 18 gauge. Please remember, 18, 20, 22. So in a scenario when you have to give patient is very hypervolemic, shock, you don't have line. If you have to push the fluids, saline, a 14 gauge, 16 gauge cannula is best appreciated. Spend time in getting that big gauge cannula than central line. Central line is always useful for giving inotropes, but if you have to rescue a patient, say in emergency, in the ER, always go for a 14 gauge or 16 gauge cannula, because as Jeevitha told you, that will give you, a 14 gauge will give you almost 300 ml of fluid per minute, while 20 gauge will give you only 80 ml per minute. Okay, so if you want to rescue a hypovolemic patient, always go for a 14 gauge or 16 gauge. In a central line, you cannot give a massive fluid infusion to save a patient, to rescue a patient. All right. Okay, there is one question. If not going any medicine through central line, see, there is no, this Jessie is asking the frequency of flushing, OD-BD. See, it's not like that. It's, it's, as I said, once, Jessie, you take your handover, you change the shift, you must know your central lines or peripheral lines are working or not, number one. Okay, so there's no OD or BD. Other thing is, if you're through peripheral line, naturally, if you're going to give it antibiotic, you aspirate first. If it is not aspirating, if the bleb is there, swelling is there, what do? You ask for a change of the or replacement of your or a change of the new peripheral line. Okay. And how much ml? See, nothing is specified, but I will still tell you, for radial arterial, use small 5 ml flush. Do not use like 20 ml. Unlike femoral, we can use more larger volumes. But for a peripheral, radial arterial, radial peripherals, always use small flush, 5 ml to 2 ml, not more than 10 ml. Okay.
One more question, ma'am.
Yeah. So, ma'am, in central line patient with immunoglobulins, no, we cannot administer drugs with that. Even immunoglobulins are dedicated port. Okay. So, yes, we give to central line. And no, immunoglobulins we can give to 18 gauge also. There's no such this thing for using only central line for that. We could use EJV also. But we cannot give any other drugs with immunoglobulins, please. It's a dedicated line. Once you finish your infusion, then we can use after flushing it. So those are the questions I have answered. I hope this session was easily understandable and a lot of doubts have been cleared. And I do hope my sisters and brothers out there, those who are caring my patients, are more enlightened and they know how to go about more in a better way. Jeevitha? Thank you, ma'am. Thank you. Yeah. Okay. There is one question. Yeah. Any other questions? Okay. No, ma'am. But the class is very clear, knowledgeable. Very good. Okay. This side, we will share the slide with you. There's a request for sharing the bundle checklist. Jeevitha will do that. Okay. Okay. And it was knowledgeable. Thank you very much. Yeah, I see a lot of thank you. So, yeah, there's one question. What will happen if we inject any drug in arterial line? So first of all, you should know, where is the arterial line going? Is it going to the heart or is it going to the periphery, away from the heart? Pankaj, Makwana? See, the very fact that any drug which you go, it is not going to go towards the heart. All right. In the arterial line, it is going to go towards against the heart. So that drug will not reach the attended or the target organ, which is why arterial lines are dedicated line only for monitoring the blood pressure, not for any injectables, not for any injections.
One more question, ma'am. Before taking samples from central line, we will withdraw the blood. So can we re-administer that blood? No.
Actually, it is, that also is a little questionable, but I suggest to get the blood back. Central line, if you're aspirating this thing, do not push the blood back. Once blood is taken, so always take a small amount.
Thanks, ma'am. Nicely explained the doubts. Yes, ma'am.
Okay.
Yeah, ma'am.
Hello.
Okay.
Yes,
So,
Jeevitha?
Sir, tell me, sir.
Jeevitha and Monica, I have
we have this already.
Ma'am, sir
Yes,
is...
sir, who is this? Dr. Shola is here. Good out. Yeah, who is this, sir? May I know who's speaking?
Hello, Monica. This is Dr. Shamsundar.
Yeah.
Yes,
sir. Hi, sir.
Yeah. How are you?
Board. Yeah.
I was just,
I'm good, sir. How are you? Yeah.
I'm good. I've been very keenly listening to both of your talks. They were excellent. I would say this is one of the best. And there was a great participation. So much, and you exactly explained, both of you, what the nurses need. And this is a way a nurse should be taught, So
yes, sir.
I congratulate Jeevitha and Dr. Monica.
Thank you, sir.
Thank you, sir.
For synchronizing so well and explained all the questions for the queries from the nurses, and with a lot of patience. And I would invite you again for another good lecture. I was so
Thank you, sir. Thank you.
Yeah. I'll be most happy to moderate that as well, sir.
On the behalf of the College of Critical Care Medicine, I appreciate both of your efforts.
Thank you so much, sir.
The zeal and into what you have explained to these classes. So with the thanks, I welcome you back again. I would.
Thank you so much, sir.
My pleasure, sir. Always my pleasure.
Thank you.
Thank you, sir. Thank you so much, sir. Thank you.
Yeah. God bless. Thank
Madam, 2 questions are there.
Go ahead.
I don't know. Can we still carry on? I'm not sure.
We can carry on, sir. Ma'am, one question is, what is the recommended amount of blood to withdraw before sampling? Usually 5 ml. What is the recommended amount of blood to withdraw before sampling?
That is what we had seen.
There is no.
Sir, will you answer the question, sir?
No, I was just telling there is no recommended amount.
Exactly. Yeah.
So as you rightly said, it should be as minimal. Just take out the whole thing from the catheter. And then, as you rightly said, don't re-push it.
Yes, sir.
Unless you're in a very sterile conditions like in a theater, you're not supposed to do in ICUs and critical care units.
All right. So the most important thing is, see, as I'm saying, stressing again and again, the triad of asepsis. First is the awareness, what you're going to do, whether it is peripheral access, central access, arterial line, and then of course hand hygiene. Strict asepsis goes without telling, without any breach in the aseptic techniques, without even saying anything. This has to go on. And third is the alertness to any first sign of your line infections or your peripheral line extravagation. So if you pick up that first, these things will follow, because early intervention is the best treatment the patient can get. But if you delay getting that sign to be noticed, then things take a little, downfall. So that is what we have to prevent. I think there's a lot of questions have been discussed. Should we close the session, or we have some more questions on board? Jeevitha?
If you find an interesting question, you can answer.
Yeah, I'm okay. I can still carry on.
I can give you another 3 to 4 minutes.
Sure, sir. Almost whatever question being asked, we have answered, ma'am.
Yeah.
And one question, what I read means, if accidentally, if you administer medication through arterial line, what could be the side effect? Somebody has written that question.
Yeah, but what have you injected?
See, by mistake.
Mistake. So, if I think you have accidental injection has been done, first is you discontinue, number one, and see for any sign of hypotension, any sign for tachycardia, fever, okay? Because a drug, it depends what you've injected. If it's antibiotic, probably it may not have so much effect, all right? If you have injected a vasopressor, that will be devastating. That will be in front of you right away, okay? If you have injected KCL, God forbid, I don't know what will happen because, patient may have an arrest or depending upon the concentration, okay? So if it's lignocaine, nothing much, I have seen an arterial injection with lignocaine, but nothing happened to the patient. But everything said and done, you have to first realize you have done that, inform the doctors, and watch for, and do not use that line at all. That's about it. Because that arterial line is going to get flushed every minute. We are flushing it by, I think, 0.2 ml per minute. Okay. So discard that line, not use it at all, and watch for any sign for any adverse events or adverse signs. And as the protocol informed the nursing in charge, adverse event form has to be fulfilled and what drug has been administered. Okay. So most important thing is at least you realize you've given that injection. Immediate alertness to the concerned parties, the doctor and the nursing in charges. All right? Yeah.
Yes, ma'am.
Okay. So, sir, should we close session now?
Yes, Monica, I think.
Okay.
Thank you.
Thank you so much, sir. Thank you.
Yeah, I appreciate that my sisters and nurses, they had a learning experience, and I hope they do practically fulfill in their practice as well. Yes. So let's see that. Thank you, sir.
Okay.
Yeah.
Thank you, ma'am.
Thank you.
So much,
Thank you.
Thank
God
you,
bless
sir.
all. Yeah, thank you.